Headline by
Right. Thank you.
headline.
Friends, good evening and welcome to you all. This webinar has jointly been organized by two IOA subcommittees, one on rheumatology and the other on presidential theme of previous year, comprehensive medical management for osteoporosis. We are lucky to have amongst us Dr. Ram Chaddha, who is also the president of IOS. But besides being the president, he took keen interest into the topic that we have been discussing since last 3 years, and he saw to it that this webinar comes to finality and is able to define the guidelines. May I request Professor Ram Chaddha to kindly give his inaugural address.
Good evening, everybody. Thank you very much, Professor Jha. Thank you very much, Professor Amarnath, the two SS, as we call them, SS Jha and SS Amarnath, who have gotten together and actually connected the dots so that each one of us are here today. This all started, as rightly mentioned by Professor Jha, 2 years back when Dr. Ramesh Sen put the initial, what would I say, the first stone of putting the Janma Bhoomi of this entire process. And from there, Dr. Atul Srivastava took it as his basic heart-sent message. And he really delivered a lot through the whole of last year. Today, he's unable to attend for some personal reasons. And I am only here to come and share the responsibility that the three of us took over the last 3 years. We have just stood by where each one of you have contributed towards what we feel is probably the most important subspecialty of orthopedics today. Why do I say that? Well, India has the largest population in the world, but has the second largest number of geriatric patients or geriatric age group in the world, which means we are second to China. However, since we are largest because our population is now just below the geriatric level. And in the next few years, besides going past China, we'll also go past China as far as the geriatric age group is concerned. And with that, with women in India outliving men, we'll probably have many more of osteoporotic patients than we've ever imagined. Hence, this is probably going to be the biggest subspecialty where geriatrics and osteoporosis go hand in hand. Yes, we have a large number of patients from the rheumatology aspect as well who suffer at a young age with osteoporosis. Dr. Jha and Dr. Amarnath have left no stone unturned. They've worked from pediatric to geriatric osteoporosis. And it's indeed a blessing in disguise that we have all these subspecialties represented today. Without taking much of your time and intervening and interjecting into this excellent Delphi consensus which has been worked out by this group, I wish you all the best and let's get going, sir. Thank you for inviting us and keeping the flag of IOA flying high. Thank you so much, sir.
Right. Thank you. Thank you, Dr. Ram. And since the subcommittee of IOA on rheumatology is also associated, so I invite Dr. Rajesh Gupta for his opening remarks. Rajesh.
Sir, I'm audible, sir?
Yes, you are very much audible.
Thank you, sir. Sorry, sir, for joining late.
No. Perfect.
So, yeah. So very good evening to all. I must thank Professor Jha for inviting me for these opening remarks for this webinar. And we all know this is osteoporosis is a global problem with around 200 million, patients all over the globe. 1 in 3 and 1 in 5 males, 1 in 3 female males and 1 in 5 males, they suffer osteoporotic fractures, And what we are seeing in our practice is just a tip of an iceberg. The problem is much more than that. And we need to, diagnose this problem at the earliest and treat it as an emergent basis. So apart from our pharmaceutical treatments, the prevention is very, very important. We must encourage the proper exercise, outdoor activities, and we encourage the children to take, the diet rich in calcium in the, their adolescent period. We all know that the peak bone mass is attained up to 25 to 30 years of the age. And after that, no peak bone mass is attained. Now, we must congratulate Professor Jha and Dr. Amarnath for coming out with the yearbook on osteoporosis, which was released in IOCON last year. And I must congratulate them also for the consensus on this, coming out with a consensus on the management of osteoporosis. There are many in many countries and many associations have their these consensus guidelines. And if we can compile our guidelines and come out with our guidelines, that will be wonderful, sir. Thank you very much for giving me an opportunity.
Thank you very much. So you have always kept yourself connected with the developments taking place towards formatting the guidelines. Friends, I have to pilot this topic, that Ioa Delphi consensus leading to evolution of guidelines in osteoporosis. I must say that it was Dr. Atul Srivastava's initiative as Vice President IOA 2021-2022. And it was in February 2021 that he gave me this additional responsibility when I was the chairman of IOA Rheumatology Subcommittee. Well, as already said by Dr. Ram, it was Professor Ramesh Sen, the then President IOA during 2021-22, that we conducted various webinars on osteoporosis, and Dr. Ramesh talked about developing Delphi questionnaires. So this was his brainchild, and he consented to initiating this proposal before finalizing guidelines to provide the authentication. Well, Atul became IOA president, and he set out on the presidential theme, strong bones and a stronger nation. Along with me, Professor Lalit Mani were the advisors, and Amarnath was the chairman of this subcommittee. Lalit Mani advocated to publish a special supplement, and this was published, and Dr. Srinivas was the editor. It was released, and we had great cooperation from the editorial team of Murali and Karthik. Well, Chinmoy had the final nail, and we are here because of his efforts being done. Well, I must say, Professor Prakash Tiwari, Professor of Nephrology, Goa, he has been 100%er in all the meetings. Well, friends, coming to the topic of osteoporosis, we have to ascertain and classify whether this patient is adult or pediatric. When we talk of adult, we have to look into whether it is primary osteoporosis, the type 1, postmenopausal, and type 2, senile and age-related. And naturally, when there is a primary, there is always a secondary one, in which all these conditions, apart from the renal problems, are there. So what are the points that we must ponder through the Delphi consensus? How do we screen? How do we initiate the therapy? And we must understand the appropriate management. Friends, we must admit that management of osteoporosis is a long-term proposition similar to treatment of hypertension and hypercholesterolemia. Apart from the pharmacological armamentarium, we have to be aware of the hormone replacement therapy, how and when to monitor our patients. We must also understand andropause, associated sarcopenia, and rehabilitation finally. Well, I call upon the first speaker, Dr. Murali Poduval, to speak on understanding osteoporosis and monitoring therapy. I will stop share.
Thank you, sir. Thank you very much. And I'll start sharing my screen.
Please.
Just let me know once my screen is visible.
Yes, it is.
Okay, so let me just keep this off. So thank you very much for this opportunity. It's been a pleasure to serve on this committee under the chairmanship of Dr. Jha and Dr. Amarnath, and of course Professor Ramesh Sen, whom I look up to all the time. So osteoporosis, if you look at definitions and background, it's a bone disease characterized by impairment, loss of microstructural integrity of bone, which leads to decreased bone mass density and increased bone fragility and susceptibility to fracture. We all know that it is commoner in female, but now we are starting to understand that it is also present in males, as Dr. Jha said about the concept of andropause. And it can be the primary or secondary to other diseases. Secondary ones are much more difficult to treat because you must treat the cause rather than the effect. In the NIH consensus called it a skeletal disorder, which is characterized by compromised bone strength leading to the predispositions for and increased risk for fractures. But the WHO, on the basis of DEXA, defines it mainly in women at the presence of a BMD less than or equal to 2.5 standard deviations below the average bone mass of healthy 20 years old. So there's a prevalence of about 12 to 20%, affects 70% of those above 80. There are a number of predisposition factors which are known, including age, smoking, family history, race, early menopause, low physical activity, etc., etc. So there are a number of risk factors which are known, and there are tools to assess the risk of osteoporosis. So when we look at osteoporosis throughout the rest of this webinar today, we will be going through some of these various factors, such as clinical types, introduction, risk assessment, prevention, diagnosis, details of pharmacological management, and non-pharmacological management. A further understanding seeks to talk about the degeneration of trabecular bone, which significantly contributes to the occurrence of spine as well as hip fracture. Whereas the weakening of cortical bone increases the susceptibility to fractures in long bones. And how does the WHO define a fragility fracture? It is a fracture which occurs because of mechanical forces equivalent to a fall from a standing height or less. And that is what the WHO defines as a fragility fracture. Screening and case finding are the different strategies for diagnosis of osteoporosis. And a term which is now being increasingly referred to is osteosarcopenia, which refers to the relation between the loss of muscle strength and the loss of bone strength during the aging process in elderly individuals. Now, coming to the second part of my talk is about monitoring. Why do you want to monitor? The current understanding is that the main reason to monitor therapy is to understand the efficacy and the compliance. Then, of course, you want to understand the fracture risk and the adverse effects also. You need to monitor. Many of these drugs have significant adverse effects. Some bullet points about monitoring. Prior to initiating treatment for osteoporosis, do evaluate serum levels of calcium, vitamin D, and possibly PTH, and also do renal and liver function tests. In the clinical usage, hypercalcemia is to be avoided when you are using vitamin D3 and calcium, and hence you should monitor serum calcium and vitamin D3 levels at appropriate intervals. And when you complete treatment and you see that you have completed a course of treatment, then repeat a BMD assessment at around 1.5 to 3 years as a monitoring effect. A number of bone turnover markers have been described, which include bone resorption markers, turnover markers, and formation markers. The turnover marker is not really being used because the process is too complex and there isn't any reasonable way to cut down on the variability out of the results. But the International Osteoporosis Foundation has recommended C1P1 NP bone formation marker and serum and urinary beta CTX1 or beta cross-lap, which is a bone resorption marker as markers of choice. And they are useful in monitoring patients on osteoporosis treatment and predicting bone loss and fracture risk. Ideally, you must document them before treatment and then follow up at regular intervals to monitor the response to therapy. This is usually at 0 and 3 months, and then 6 months, and so on. The recommended least significant change for serum bone turnover markers is 30% compared to the baseline level. When in primary osteoporosis, if you use allopathic therapy in conjunction with other therapy, then you must continue the allopathic therapy irrespective of recommended alternate medical therapy. And with that, I conclude my presentation. I thank you very much for your patience.
Right. Please stop sharing. Well, friends, up to this place, there was a scope to have a theoretical kind of discussion. From here onwards, we have had 5 sets of questions circulated. So all the presentations hereafter will concentrate on those questions that have been circulated. Right. So Dr. Murali has conceptualized osteoporosis beyond its definition and has demystified the horizons bordering osteoporosis in its entirety. Monitoring, of course, he has detailed. Now is the turn of Professor Ramesh Sen, who has conceptualized this Delphi consensus. He talks on prevention and decision making and will confine himself to only the questions that have been framed. Professor Ramesh Sen, please.
So, good evening, everybody. And as we understand, as Dr. Jha has told about, that we'll be talking about specific questions we were circulated and accepted to a significant level. First was what to do if somebody is healthy. In that kind of a question, the statement which has been accepted and put forward is that referring to physiotherapy center for prevention of osteoporosis is not warranted if the patient is otherwise healthy. Regarding the making up of a peak bone mass, the statement has been that sports activity and exercise are not only for children and adolescents, but also in adults up to the age of 30 years. They all should be encouraged to increase the peak bone mass, because that has to eventually serve as a bank through which the supply of this calcium and this thing has to go on through the life. Now, how much an activity somebody has to do? Regarding that, the statement has been that a regular planned physical activity like weight bearing or resistant exercise for 30 minutes at least, 4 times a week, that is recommended for a person for prevention of osteoporosis. Next statement is that we must understand that there are secondary osteoporosis also, or secondary contributing factors which lead to osteoporosis. So if we take care of the primary problem which is causing the secondary osteoporosis, we can prevent the osteoporosis. So the statement is, to prevent secondary osteoporosis, it is pertinent to simultaneously treat the primary disease. Next is, if we don't have a screening policy, whenever there is a fragility fracture, these will serve as a kind of a case finding strategy. So the statement is, in absence of a screening policy, a case finding strategy is employed where patients with fragility fractures or those with a high risk for fracture should be identified for further investigation and management of osteoporosis. We all appreciate that the elderly people with osteoporosis or likely to have osteoporosis are likely to have a falls which will lead to fractures. And the statement which has been accepted upon is that falls and fracture prevention strategies for elderly people include measures like identifying and eliminating the risk of falling, fall prevention exercises, eliminating obstacles, improved lighting, and use of hip protectors. And a very important thing we have to appreciate it, that how to get the people going for that kind of an exercise. It is group exercises. So the statement which has been made is attending group exercises should be allowed because patients feel
Your PPT is not moving.
Sorry, sir, at my place it is moving.
Okay, now it is okay.
Okay. So the patients feel better psychologically and become more punctual. And this is the summary for the prevention of osteoporosis. The second task which has been given is decision making in a particular situation. Is it okay, Dr. Jha, sir?
Yes, yes.
So that it was about when the patient is less than 40 years and who are on glucocorticoids, we have to do the risk stratification, and that will depend upon the prior history of fragility fracture, Z-score, prednisone dose, and bone loss as we measure by DEXA scan. And they should be classified into 3 levels of risk: low risk, medium risk, and a high risk. Next point is decision to initiate osteoporosis therapy in patients more than 40 years who are on glucocorticoid therapy is based on risk stratification, where we take into account the glucocorticoid adjusted WHO-FREX2, lowest T-score value, and the history of fragility fracture. And again, these are classified into low, medium, and high risk. Next is when the patients are starting glucocorticoid therapy with prednisone dose 2.5 to 5 milligram per day with a planned duration of treatment of more than 3 months, these people should have their BMD and FREX score calculated at the start of therapy, and preferably at this months, as long as glucocorticoid therapy is every 3 months as far as the glucocorticoid therapy is continued. Then we have to look for the fragility fracture. Whenever there is a fragility fracture, we must start the treatment for osteoporosis, and even when there is normal BMD or there is no other bone metabolic disorders. And the last is individual with the previous fragility fracture, especially in the weight-bearing areas such as hip, spine, and wrist. These people are more prone to develop severe kind of an osteoporosis. That must be kept in mind. So these are the 5 statements which has been made regarding the decision making. Thank you.
Thank you very much, Professor Ramesh Sen. And now is the turn of, just a minute. So Srinivas speaks on screening of the patients. Dr. Srinivas.
Thank you, sir.
Srini, you need to go to full screen. There is some issue.
Oh, sorry.
I think just duplicate the screen and go to full screen. Yeah. Just push F5, F5, F5.
Slide mode.
F5 doesn't work.
One sec. Sorry.
But just go to slideshow, just do Control minus and minimize it a little bit. Yeah, that's it. Correct. Thank you.
Sorry about that. Good evening, everybody. I would like to thank Professor Jha, Dr. Amarnath, and the Osteoporosis Council for this opportunity. I have about 13 points to cover. I would request about 6 minutes for this talk. Just a small background about screening. It's defined as a presumptive identification of unrecognized disease or defect by application of tests, examinations, or other procedures as defined by Wilson and Jungner in 1968. And there are different types of screening. I'll skip the details. The 2 main ones are the mass screening and case finding as mentioned by Professor Ramesh. And there are criteria laid down for screening, and osteoporosis fits most of the criteria. A screening may be done to detect risk factors or diagnose osteoporosis, identify those at risk or who have fragility fractures. And these are the tools available at our disposal to do the screening. And there may be some overlap with my next speaker. I'll try to minimize it. The tools are given here. We apply these tools at different stages depending on what we want to screen for. There are many questionnaires that are in use all over the world, but let's focus on the most useful ones for our population. Some statements from the Delphi consensus. First, the OSTA is the osteoporosis self-assessment tool for Asians, is useful to identify the need for further investigations and interventions in postmenopausal women. It is recommended by Singapore's clinical practice guidelines, and OSTA stratifies osteoporosis risk using just age and weight, and it's easy to do. The male osteoporosis risk estimation score, or MOS, is a proven method for identifying males at risk. The score system is developed for primary care and considers age, body weight, and COPD history. A MOS score of 6 or higher indicates an increased risk of osteoporosis in males 60 years or older. It has a sensitivity of 0.93 and specificity of 0.59, which is good for a screening test. WHO's FRAX tool assesses the 10-year risk of major osteoporosis, osteoporotic fractures, and hip fractures. It estimates risk using clinical risk variables and femoral neck BMD. A systematic review found that a two-step screening method is useful, and including FRAX risk assessment and BMD testing for those above a risk threshold may reduce clinical fragility fractures and hip fractures slightly compared to no screening at all. FRAX calculation in diabetes may be modified to enable more patients to have a DEXA scan, and the strategy using rheumatoid arthritis in the calculation as a risk factor identified more patients than adding 10 years of age during the calculation. DEXA is primarily for diagnosis and is used for screening in resource-rich countries, but difficult in resource-limited countries. This is the next statement. The best position for screening for osteoporosis by X-rays is lateral view of dorsolumbar spine. And this is useful in resource-strapped areas. Although there is no direct reference or citation to this statement, DEXA in this position has been reported to have advantages. The other modalities include CT scan, bone turnover markers, has been mentioned before. They have limited role in screening. Ultrasound, some expenses involved and have limited role in screening. In inflammatory, this is the next statement. In inflammatory arthritis, any patient with rheumatoid arthritis greater than 10 years should be screened irrespective of age and sex, as the risk factors to develop this are higher age, lower BMI, steroids, and menopause. It's reported that even among patients with recognized risk factors, there isn't a routine practice of screening for osteoporosis, so it's important to screen. Guidelines suggest that women over the age of 65 and postmenopausal women under 65 with additional risk factors should be screened. So those who are postmenopausal more than 5 years with rheumatoid arthritis require screening. Screening should be done in SLE patients on 7.5 milligram prednisolone for more than 2 years. The risk in this group is related to age, steroids, duration of disease, and menopausal state. In ankylosing spondylitis, anybody more than 40 years should be screened. Disease onset is usually between 20 and 40 years, and these patients are at risk of osteoporosis. Men with age of more than 50 years with risk factors are at risk of osteoporosis and should be considered for screening. And the US Endocrine Society makes a similar recommendation. We know postmenopausal women are at risk. Even those who have had hysterectomy are at risk of developing osteoporosis. It's difficult to say when they have attained menopause because of the hysterectomy. And the way to assess this is by doing FSH, which can guide as a marker for ovarian function. It's important to note that this study primarily focuses on ovarian function and did not directly link FSH levels to osteoporosis risk. So the National Osteoporotic Foundation recommends BMD testing for women aged 65 and older, postmenopausal women, and men between 50 and 69 with risk factors, and those who have sustained a low trauma fracture after the age of 50. And screening is recommended once every 2 years, starting age 65 years or younger with risk factors by the American College of Obstetricians and Gynecologists. Just to brief summary, osteoporosis is a silent disease. It's important to identify those at risk or diagnose early using an appropriate tool to prevent fractures. Case finding strategy is useful in resource-limited countries. It is important to keep in mind the rules or adjustments in screening and special conditions. Thank you very much for your attention.
Thank you, Srinivas, for detailing about the patients to be undertaken for screening and the modalities for screening. So identifying persons at risk, it is possible to evaluate even yourself or any patient without any gadget. Well, diagnostic investigations are so important, and Gururaj Sangondimath will be talking about the various diagnostic procedures.
Thank you, sir.
All right.
So can you see my screen, sir?
Yes.
Okay. Just okay. Thank you once again for giving me this opportunity. So I'll just try to stick on to the questions which were designed. The investigations which imaging modalities which we can do in osteoporosis, the most well-known DEXA and digital X-ray radiogrammetry and quantitative CT, quantitative ultrasonography, and pulse echo ultrasound and EOS imaging, which is the new thing which is coming up. So coming to DEXA, the question was designed dual energy X-ray absorptiometry, that is DEXA, is the current gold standard investigation recommended by WHO for the diagnosis of osteoporosis. Yes, the response is yes, and we all know that it has been the best clinical tool for assessing bone mineral density till now, and the National Osteoporosis Foundation has recommends using FRAX tool to calculate fracture risk if at all the T-scores are between -1 to -2.5 in the spine or femoral leg or total hip region. And usually whenever you do DEXA scan, you have to do at least 2 sites. And it has been gold standard, and it has been variedly used and frequently used because it is simple, quick, painless, and safe examination. Uses very low dose of dual X-rays that can be repeated safely over time. And the main applications of DEXA are to diagnose osteoporosis and to monitor the response to the treatment. It can be also used as a screening tool, as we discussed in the previous talk, and it also used for predicting fracture risk in combination with the FRAX score. And these are the indications where we have to do DEXA scans, especially females more than 65 years, males more than 70 years, without any indication or without any symptoms, we have to do DEXA scan. And females less than 65 years and males less than 70 years with risk factors which increase the fracture risk have to be screened with DEXA scan. Interpretation of these 2 lines are very important. For patients with T-scores of neck of the femur, spine or hip area between -1 to -2.5, the National Osteoporosis Foundation in the USA suggests to use FRAX tool to determine the risk factor. But it doesn't same apply to the Indian patients because it can underestimate the fracture risk because it is not yet validated in Indian population. So again, the same thing, ISBMR definitely says the fracture risk can underestimate the fracture risk with the DEXA scores. The second question was to differentiate between osteopenia and osteoporosis. Is DEXA critical? Again, yes. And why we need to differentiate between osteoporosis or osteopenia is because in osteopenia, you can only treat these patients by lifestyle changes. But then osteoporosis often necessitates the chemotherapy or a medication. And identifying osteopenia early allows preventive measures to slow down its progression. Recognizing osteoporosis ensures timely intervention to prevent fractures. And it also helps in initiating the treatment and monitoring the progression. So coming to limitations of DEXA, the radiation exposure, even though we have found that the radiation used is very, very less, two-dimensional measurement, so it doesn't assess osteoporosis in terms of three-dimensional volumetric like QCT does. So it can be sometimes erroneous, and degenerative alterations like the osteophytes and the degenerative sclerosis can actually give false positive BMD results, which actually underplays the risk of fractures. And structural interferences like spinal structures, osteophytes, or post-surgery artifacts or aortic calcifications can also give false BMD values. So we have to interpret the DEXA scores in these patients very carefully. Again, in very lean or very obese individuals, the BMD results can be erroneous. Lack of microstructure information really causes problems in terms of assessing the real fracture or real porosity. And there can be machine variability. If you do a DEXA scan in the same person in different machines, you can get different results. So we have to be, again, very careful. Whenever we want to assess the progression or the response to the treatment, it's always you have to do the DEXA scans in the same machine. And again, it cannot differentiate between trabecular and cortical bone, because we know that trabecular bone is very important when it comes to osteoporosis. And age-related reproducibility is again a question. Contraindications, bilateral hip replacements, because there's too much of metal implants in the area, like a long segment of the spine is fixed. In pregnancy and in obese patients like 120 to 130 kgs, and recent contrast studies which can give again higher BMD value. Next question is whether in diabetes DEXA is inferior, or DEXA may not be able to detect the loss of structural integrity of the bone, which can increase the fracture risk. Yes, definitely the diabetes alters, and we all know that diabetes causes porosity in the bone. And because DEXA cannot assess this structural integrity, definitely it can give a erroneous fracture risk. Coming to, we need a fracture calculation modifications in presence of diabetes. Again, the response is yes, because DEXA underestimates the risk of fractures in diabetes because it cannot actually identify the microstructures. And how do we deal with it? In the fracture scores is combined with the trabecular bone score has to be combined in diabetes patients. And the patient's age is increased by 10 years in calculating the FRAC scores, again, when it comes to diabetes. And the T values of the BMD is regulated appropriately to the minus 0.5s when it comes to diabetes to have a proper BMD measure. Again, coming to HbA1c and FRACs are basically, we know that because it increases the fracture risk, they are inversely proportional, and you need to adjust the points accordingly, as mentioned in this slide. In terms of fracture measure, osteoporotic fracture probability is reduced by 0.915 points, and for a hip, it is reduced by 1.438. Coming to X-rays, again, the architecture or the alignment of the bone which determines whether there is a fracture or not, and then how do we identify osteoporosis in these patients, especially if you have a cleft signs, Kummel's disease, or you see a pseudoarthrosis with the decreased bones and density, it gives an idea of osteoporosis. So in terms of that, coming to the next question, that is altered architecture of the dorsolumbar spine in lateral view radiography is a method for vertebral fracture assessment. Yes, it is a method for assessment of the vertebral fracture assessment, but it's not an accurate method because it has got a lot of basically intra-observer and inter-observer variabilities. So X-ray is not a great tool to assess vertebral fracture assessment. There is criteria how can we identify basically the fracture collapse, that is height loss of more than 15%, kyphotic angle of more than 10 degrees, and presence of intervertebral cleft sign during the follow-up is again a indicator of the decreased bone density. Again, we have a AO. There are 5 types of subtypes. Again, you can identify all these based on the. Coming to quantitative USG ultrasonography, the question was whether quantitative ultrasound screening of heel has a limited role in osteoporosis. Yes, definitely, the quantitative ultrasound method has a very limited role in osteoporosis diagnosis and prognostication. So if you see this slide, the sensitivity analysis of osteoporosis detection using the quantitative ultrasound is very poor. And again, for osteopenia is also, it's very poor. So the conclusions actually overestimate the value of ultrasound in diagnosing the osteoporosis. So the conclusion is quantitative ultrasound is not a good tool in screening or diagnosing osteoporosis. Coming to bone turnover markers. So we all just now discussed, I'll just skip this slide. So there are mainly 2 bone turnover markers. The question was formed based on that. That is, recommended bone turnover markers for bone resorption are basically BCTX1, that is the C-telopeptide, C end of the telopeptide of the for type 1 collagen, and B cross labs, or bone formation marker like E1N. Yes, as discussed in previous PPDs, that these have to be done before you start the treatment so that you can prognosticate the basically your treatment. So in terms of bone resorption markers, CTX1 and B cross labs are the markers which have to be used. And in terms of bone formation markers, that is E1NP. And the significance of CTX is elevated CTX levels indicate high bone turnover, potentially signaling underlying issues such as malabsorption and osteoporosis medications or poor adherence to the treatment. So definitely when we have this elevated CTX markers, even after the treatment, so we need to find out for any secondary osteoporosis causes which need to be treated. And if your CTX markers remain significantly higher even after treatment, you might want to change it to a bone forming agents like teriparatide. Coming to the other question for monitoring patients on osteoporosis drug therapy, bone turnover markers in blood and urine may be used. Yes, bone turnover markers in blood and urine can be used, but the only thing is the urinary basically N-telopeptide markers are less sensitive and less useful as compared to blood markers. So as much as possible, bone turnover markers of blood have to be used for identifying that basically progress. Coming to quantitative CT, so we have different kinds of CTs because a QCT, it's a volumetric BMD measurement. It doesn't depend upon the body size and it is more sensitive to change in bone density due to disease or the treatment. So it can be used for screening tool or as a diagnostic tool or treatment. The only problem as compared to QCT versus DEXA, basically the QCT is definitely more sensitive, better to use, but the problem is with the radiation of the QCT. And some newer methods are there like high resolution MRI, high resolution peripheral quantitative computer tomography, and multi-detector computer tomography. These are used to diagnose the microstructure of the bone and diagnose osteoporosis based upon that. Especially the high resolution magnetic resonance spectroscopy provides quantitative marrow adiposity measurements, and which is crucial for estimating bone quality. MRI definitely its advantages because it has no radiation, but it has disadvantages like it can be only done right now in peripheral bones like calcaneum, distal radius, and tibia. So it's not really into a practical usage. Coming to all the basically the modes which are used to diagnose and screen the osteoporosis, DEXA and QCT stands out, and DEXA has been the gold standard at present for diagnosing and prognosticating the osteoporosis treatment. EOS is the new tool. Again, it has got a very less radiation dose, and it creates a 3D reconstructions, and it aids in identifying fracture risks in osteoporosis patients, and it is really promising for the future. Coming to the last question, that is in the clinical usage of calcium and vitamin D, hypercalcemia results into serious complications that require intensive and emergency care are to be avoided, and hence serum calcium level should be monitored. Definitely yes, because hypervitaminosis D and hypercalcemia are known problems of osteoporosis treatment. So we need to monitor them whenever we are doing osteoporosis treatment. Coming to this last question, that is in patients with osteoporosis, correct serum calcium levels with respect to serum albumin levels need to be considered when deciding the management. Definitely yes, because hypoalbuminemia can lead to falsely decreased calcium levels because it is bound to the albumin. Whenever the albumin is less in the blood, it can give a false sense of hypocalcemia. So always calculate your corrected calcium levels using this formula of 0.8 multiplied by normal albumin minus patient albumin plus serum calcium. And also the hypoalbumin levels are directly related to causing osteoporosis. So we need to always measure or take in consideration of albumin when we are taking osteoporosis. So it is just a representation how you calculate your corrected calcium levels when you have a hypoalbuminic patient. So that is how it is calculated. Thank you.
Thank you. Thank you, Dr. Sangondimath. Please stop sharing. Right.
Gururaj.
Yes, and his title is Dr. Sangondimath.
Yes.
So next presentation is by.
So we can't hear your voice.
You can't hear me?
We can hear you, sir. We can hear you.
Okay. So now next presentation is Dr. Amarnath, who talks on nutrients, calcium, and vitamins. Friends, you will be surprised to know that when a child is born, the child has only up to 30 grams of calcium, but it rises quickly after birth, and in adulthood, it is 1200 in women and 1400 grams in adulthood. So we have little more than 1 kg of calcium. So Dr. Amarnath, please, the calcium.
Thank you, sir. I will start to share the screen after you stop.
All right. You can still, okay.
Yeah. Thank you, sir. Is everybody able to see my screen?
Now, yes.
Great. Thank you. I should thank IOA and all the Delphi Council members for having given this opportunity and making it a possible, milestone that we have, and definitely going to be giving more time for others who have more questions than me. Now, the first question is, hereditary fracture is a definite indication for initiation of therapy for osteoporosis. So, yes, when there is a hereditary fracture, you need to have the therapy initiation. Which therapy, what to be done, the other questions are there. I'm not going to be coming into interfering with overlapping of the question that's going to be there. Hence, I will not take too much of that. Yes, it is a must, and you need to initiate that. And the second question, which is almost similar, but not. Person aged more than 50 years and the history of rigidity fracture is also an indication. There, it was general, but here we're talking about very specific condition where a 50-year-old with the fragility fracture is also an indication for initiating. So that is what is going to be, and I'm going to put the references later in the slides. And I thank Sitanshu for helping me out with a lot of other parameters that we have. Q3. Now, prior to initiating treatment, this is very, very important. Now, whether we treat bisphosphonates, be it MAD, or are we going to go with the teriparatide or the future drugs coming in, you and I need to make
Your voice is not coming.
sure that we have adequate levels of calcium. You and I know. Sorry, sir?
No, fine. Now it is okay.
Hello?
It is okay.
It's
Go
coming?
ahead. Go ahead. Yes.
Right. Thank you, sir. Thank you. Thanks a lot. Thank you. So, the vitamin D and kidney functions, liver functions, and parathormone are very, very inclusive in terms of assessment and making sure, making sure that we give the treatment and they're adequately monitored. The next question, this is extremely important here. Now, we talk about hypercalcemia, hypocalcemia, or hyper. All those parameters are very important. In the clinical usage of calcium and vitamin D, and especially vitamin D3, the question is, hypercalcemia resulting into serious complications is to be avoided, hence should be monitored. And Dr. Murali picked up this and then gave us a clue in all the comprehension of the kind of treatment. This is one question which you and I, as practicing orthopedic surgeons, need to know this and make sure that we monitor the levels. People say, oh yeah, calcium levels are going to be normal anyway. No, that is not the point here. We talk about hypercalcemia causing into a serious complications, which we have seen time and again, which is a preventable one. Yes, it's required. And the next question, use of non-steroidal anti-inflammatory drugs in the pain management of osteoporosis should be restricted, and patient receiving same should be monitored for potential side effects. All of us know the side effects of the NSAIDs, and many of the patients are all on the either PPI, proton pump inhibitors, or even H2 receptors and all that. So you and I need to be very, very clear. Plus, anti-inflammatory drug has a direct relationship with our osteoporosis. Hence, we need to be very careful in what and how we manage it. Certain other questions are there, which is overlapping with the osteosarcopenia. I'll not take much time there, but this is an extremely important point. When we're treating osteoporosis, osteomalacia has to be addressed very, very fast. Now, for that, with the kind of journey that we have had in the last 3 decades and being a part of ISBMR, which is again a sister concern of ASBMR, Indian Society for Bone and Mineral Research, we have done a lot of work on this, and the safest way to do that would be 60,000 international units per week orally. Doesn't matter what modality you're going to give. You're going to give an enema capsule or a nanoshot, whatever you call it, it has to be given. Injections, please avoid, we say. Injections are on a higher end, 300,000 or 600,000. Unless the vitamin D levels are so low, only then injections are monitored and given. Hence, this is correctional or loading dose, what we call it as, for 12 weeks, and then do a maintenance of once in fortnight or once in a month. So that, accordingly, the clinician can decide upon. The next question, preferable oral calcium salts. Obviously, there's a lot of debate on that. Carbonate and calcium malate, citrate malate has been very widely accepted. One, because of the elemental calcium content, and the bioavailability. These are the two things that you and I need to talk about. Plus, patients have their own dietary calcium, which is coming from their diet on a regular basis, day in, day out. Hence, we need to monitor that. And these are the two preferable salts. With this, I run through a couple of my slides with the references that's been taken here. And I end my talk and give more time for my colleagues who have got bigger, larger questions in their presentation. I thank each and everyone for patient hearing. Thank you. I'll stop sharing now.
Thank you, Dr. Amarnath.
Thank you, sir.
Well, Dr. Srinivas, may I have the permission to speak on bisphosphonate place for non-biological anti-resorptives? Well, the question is, ideal indication of bisphosphonates are primary adynamic osteoporosis, which is high turnover bone disease. There was some typographical error in putting this question. It will be modified to ideal indication of bisphosphonate is primary, adynamic is deleted, is primary osteoporosis, and also osteoporosis with high turnover bone disease. While discussing, we will come to that adynamic is never a high turnover bone disease, rather it is a low turnover bone disease. Now, IV zoledronic acid 5 milligram can safely be repeated continuously for 3 years, and it reduces fracture risk not only in spine, non-spine, and hip, and also prevents recurrence in hip fractures. Right. Now, avoid bisphosphonate in pregnancy, lactation, and in patients who have undergone recent dental procedures. Question 4. Vitamin D deficiency may precipitate hypocalcemia and bone pain. Hence, evaluation of serum calcium and vitamin D must be evaluated prior to administration of bisphosphonates. Well, alendronate and risedronate should be preferred for fracture risk reduction in spine and hip. Bisphosphonates do not affect fracture healing and can be safely given either oral or IV 2 weeks after surgery when the wounds have healed well. Question 7. After drug holiday following anti-resorptive therapy, treatment should be recommended after a gap of minimum 2 years. We will be discussing this in discussion part. Drug holiday of 2 years following bisphosphonates may be recommended. Therapy with teriparatide ideally not recommended after 2 years, but can be considered if the patient remains at or has returned with high risk of fracture. Question 10. Once there is a complication associated with therapy of bisphosphonate, like osteonecrosis of the jaw or atypical fracture in the past, further therapy with bisphosphonate is contraindicated. Extending the same question further, bisphosphonate therapy has the advantage of decreasing risk of various cancers, including breast, colorectal, and gastric cancers, and the references have been given. So 1 plus point. Apart from drug holiday and development of atypical subtrochanteric fractures, bisphosphonates may be discontinued also on achieving number 1, there are no osteoporotic fracture. Number 2, no high fracture risk. Number 3, hip T-score is more than minus 2.5. Question 13, zoledronic acid 5 milligram IV once annually should have prophylactic peri-infusion paracetamol. Hypocalcemia once again must be brought to normal and EGFR must be more than 30 ml per minute before deciding to infuse zoledronic acid. Well, after stopping bisphosphonate upon correction of osteoporosis, the patient should be monitored every 1.5 to 3 years, preferably with a BMD assessment. That brings to the end of my talk, and now I will request Dr. Bharat Dave, who speaks on Teriparatide and Denosumab. Dr. Bharat Dave, please.
Good evening. Thanks for giving me the opportunity to share my experience related to the Denosumab and Teriparatide. For me, the molecule Teriparatide, I call this as the miracle molecule. And the classic example has been the rate of vertebroplasty has gone down to 0 after the awareness increased. Use of Teriparatide and the diagnosis of osteoporosis made earlier during the treatment. So Teriparatide should be used continuously up to 2 years as of today. And there is ample literature support that tells us that it can be used for osteoporosis management. And it can be used beyond 24 hours as well. There has been studies related to the same as well. So clinical trials, they say that it should be continued beyond 6 months, up to 6 months. If you stop after that, the resorption starts. So that is very important that we should continue the full course of therapy, and that is 24 months. Combination therapy has an advantage over the severe osteoporosis. Our own Dr. Sunil Marwa has published in Indian Journal of Orthopedics the same that it is superior. And there are another articles also, they suggest that it is superior as well. So combined therapy has been advocated, but there is one article that shows that a high amount, mean teriparatide 40 microgram and denosumab increases the spine and BMD than the standard combination therapy. So people have done the trial on the high dose of teriparatide as well in order to get the better outcome in severe osteoporosis. And we do get patients in the clinic who has -5 DEXA as well. Teriparatide lifetime use, risk of osteosarcoma. That has been the red label molecule, which is in the box of that. But the Eli Lilly and a lot of other, they have proven beyond doubt that it does not cause osteoporosis. So it does not cause osteosarcoma. So beyond 2 years, 90% of the rats' lifespan was 2 to 3% of the humans. So that itself shows that, you know, we are comparing with the rat, and they were given the high dose of the teriparatide as well. And that also had 2 to 3%, you know, the osteosarcoma. So that's been, you know, red label, but that hopefully will go out of the window soon as well. That's been in the process of the FDA. While all agree that teriparatide used in the treatment of osteoporosis and also to prevent bone fracture, but off-label use of teriparatide can be effective in non-union and delayed union. I'm sure we all have been using this, and it is also written in the literature that stimulating the osteoblast, reducing the osteoblast apoptosis, increases the callus formation, and that gives a mechanical strength, and that has been proven in the systemic review, which was published in Indian Clinical Orthopedic Trauma. And the conclusion has been limited evidence suggests that subcutaneous use, yes, obviously, whenever you go to the molecules, the drug therapy, Lilly's recommendation, they say that it should not be used, but we have been using it in delayed union, and that's been supported by this article too. Unexplained hypercalcemia is contraindication to the use of teriparatide. Yes, the safety has been discussed with this decade of experience article in the JBMR, and they say that unexplained hypercalcemia is contraindication because teriparatide itself causes hypercalcemia, and if there is hypercalcemia, it will lead to further hypercalcemia, and that is not to be used as well. So we have to really evaluate the calcium level. Metastatic cancer is an absolute contraindication for teriparatide. There is enough literature to mention the same. And one of these articles, it may accelerate to pre-existing malignant tumor. And that is the case report. Safety of anabolic steroid, it says that PTH receptors, they are found into the tumor cells as well. And so that is why it is likely to aggravate the metastatic process. So that is why it should not be used. Same article has been written in the Indian Endocrine Review as well. So that also says that it should not be used, and that's been review article as well. So there is n number of articles in the literature. They suggest that it is contraindicated. Do not use teriparatide if PTH is above normal, hypercalcemia, elevated alkaline phosphorus, and metastatic cancer. I mentioned about the same, but when it is PTH is high, we should not be using it as well. There has been shown that calcium level can also increase as well, which I mentioned earlier. So PTH has to be evaluated before starting teriparatide therapy. So PTH and serum calcium level has to be evaluated because both are likely to increase with the parathyroid hormone treatment, means teriparatide treatment. Ideal sequential therapy in osteoporosis begins with teriparatide followed by denosumab or bisphosphonate. This is the sequential therapy. Everyone should be aware, those who are treating osteoporosis, about the sequential therapy. N number of literature support shows that there is good number, we have to continue the lifetime therapy of osteoporosis after stopping teriparatide. And it is classically explained like a pot which is half empty, like in osteoporosis, and then you need to fill it up with osteoblastic, that is teriparatide, and then you need to stop leakage after it's been filled up by continuing denosumab, means osteoclastic, and bisphosphonate, that is anti-resorptive therapy. A drug holiday anti-resorptive therapy treatment should be recommended after a gap of minimum of 2 years. I think it's been spoken earlier as well in the previous talks. So there is enough literature to suggest that as well. But beyond 2 years, I think it has increased. Discontinuing alendronate beyond 2 years was associated with increased risk of hip fracture. So I think 2 years, 1 to 2 years is an expected drug holiday. Beyond 2 years, the literature says that it can increase the risk as well. Drug holiday, another few articles mentioning the same as well. Drug holiday, when, why? And they say that it should be existing data says optimal length of drug holiday has not been established, but existing data suggests 5 years of alendronate therapy, 3 years of zoledronic therapy, and 1 year of risendronate therapy needs drug holiday after continuation of the therapy as well. Following inadequate response to oral anti-resorptive therapy, denosumab may be administered. Yes, this is something which is also written in the literature as well. Perhaps this could be correlated with the absorption of the alendronate, which may not be adequate, or patient compliance. Denosumab exhibits advantage over alendronate because it has got superior outcome. I think after starting denosumab, the literature and the overall decrease in the BMD occurs, increase the BMD occurs because of the same denosumab. It has got both osteoblastic activity and suppression of osteoclastic activity. That's been written in the literature as well. So that is cellular level mechanism. That is what happens. Denosumab exhibits advantage over alendronate, demonstrates superior outcome on the cortical bone, and reduces the cortical porosity in various regions of radius, tibia, and hip. That's been supported in the literature as well, that it is denosumab versus bisphosphonate therapy, and there was no superiority found in the risk assessment, but it is better, you do get good outcome with the denosumab therapy. Additional indication of denosumab, I think it's written in the literature as well, that giant cell suppress, it means it is used for the giant cell treatment as well. While on the treatment with Denosumab, if a patient develops fragility fracture, this is very important. Anabolic teriparatide may be a preferential combination. Yes, it is. That is how you can treat that, and that is enough in the literature as well. But the reason for that is transient loss occurs after starting the teriparatide therapy and discontinuing the Denosumab therapy. And that is where we need to protect patient, because they are likely to develop the new fracture in that time span. So that is very important. So that is also written in the literature in quite a few articles as well. Do not use teriparatide if the PTH is above normal, when there is hypercalcemia and elevated alkaline phosphatase and metastatic cancer. But if the cold chain is not maintained, then also teriparatide should not be used, and cold chain has to be maintained, has to be maintained, has to be maintained. There are no articles, but if cold chain is not maintained, then it will become like a water pen. Thank you for patience hearing. Thank you.
Thank you very much for doing great justice to this subject. Now is the turn of secondary osteoporosis, and Professor Prakash Tiwari will detail about the renal diseases and steroids. Professor Tiwari, I stop sharing. Yes, please.
Yes, sir.
Yes, your screen is visible.
Yes, sir. Good evening, sir. Thank you for giving this opportunity to talk on the osteoporosis secondary to renal disease and steroid.
If you can make it full screen, right.
It's now full, sir. Can you see?
Okay, fine. Go ahead. Not full. Yes, now it
Right,
is.
sir. Right, sir. Abhi ho gaya.
Yes, sir. As you know, chronic kidney disease is a worldwide public health problem and associated with osteoporosis and renal osteodystrophy. But osteoporosis severity and treatment varies in different stages of chronic kidney disease that is classified as GFR from more than 90 to less than 15 from stage 1 to stage 5. Osteoporosis, along with bone metabolic disorder, occurs in all stages of chronic kidney disease, and this is already presented in bone key reports and by P.D. Moller in American Journal of Kidney Disease 2021. What this study showed that osteoporosis occurs with the chronic kidney disease, mineral bone disease in patients with chronic kidney disease. Osteoporosis mainly seen in the stage 1, 2, and 3. But in stage 4 and 5, it is usually associated with renal osteodystrophy. How to diagnose this osteoporosis is there. DEXA can be used to diagnose osteoporosis in early, like stage 1 to 3, but in late stage, it's sensitive. But you have to rule out the renal osteodystrophy by doing the other parameters like calcium, phosphorus, uric acid, serum PTH, and other investigation. This is another cohort study that shows that this DEXA is useful to assess the BMD and predict fracture risk even in the late stage of chronic kidney disease. This is another meta-analysis reveals the same sensitivity as DEXA. Regarding the treatment, as already discussed, calcium, vitamin D3, and other treatment is effective to increase the mineral bone density. But definitive treatment is either bisphosphonate therapy is contraindicated for the treatment of osteoporosis in chronic kidney disease with GFR less than 35 ml per minute. This paper in Clinical Journal of American Society of Nephrology that showed that elidronate, abadronate, desidronate are that is FDA approved when you can use this GFR more than 30 to 35 ml per minute. If it is you are going to use below that GFR, this retrospective study showed that there is a modest increased risk of chronic disease progression in cases where bisphosphonate used in patients with GFR less than 35 ml per minute. This is another study that revealed the same thing can't use if GFR is less than 30 to 35 ml per minute, where there is no increase in the DMD in those patients. Regarding teriparatide may be administered in adynamic osteoporosis patients with chronic disease with GFR is more than 30 ml per minute. This is another paper in the C. Johnson, and this suggests that teriparatide 20 to 40 micrograms subcutaneous daily is GFR is more than 30 ml per minute. But you have to see for the hypocalcemia, and other complications I discussed by the previous speaker. This is the observational study, and that revealed that teriparatide use resulted in vertebral and non-vertebral fracture risk reduction in patients with GFR more than 30 ml per minute. Again, osteoporosis in chronic disease patients, denosumab can be used in osteoporosis in chronic disease patients across all stages of glomerular filtration rate and consider relatively safety profile. This another paper by the Clinical Journal of American Society of Nephrology that showed denosumab 60 milligrams subcutaneously every 6 months used at any EGFR. But only thing that one should be cautious about hypocalcemia when you are using in the late stage and patient on dialysis, and that hypocalcemia should be taken care of. And if patient has the juvenile patient, or you stop the denosumab after 3 months, some patient may develop hypercalcemia. That should be taken care of. That is a randomized controlled trial in just so that the denosumab is effective in reducing fracture risk and not associated with increase in adverse event among patients across all stages of glomerular filtration rate. This is another randomized controlled trial supports the statement. Another question is while risk for developing osteoporosis on the use of prednisolone at dose more than 20 milligrams per day for 1 month is sufficient. The dose for developing osteoporosis is at more than 5 to 7.5 milligrams per day for 3 months. This is in Osteoporosis International. This is a consensus statement, and this revealed that it was concluded that prevention and or therapy of glucocorticoid induced osteoporosis should be considered not only for the post-menopausal female, but also for the osteopenic pre-menopausal female and for the males put on daily dose of at least 7.5 milligram equivalent prednisolone that is expected for last at least for 3 months. Another question was the daily tapering schedule. While using prednisolone, had a definite pattern under 40 milligram daily, taper by 5 milligrams every week. This was a study published in the British Journal of Clinical Pharmacology 2021. And this is there a safe and effective way to win patients on the long-term glucocorticoid. And this is showing an tapering regime, different regimes stored here, and this concluded that it is reasonable to taper the prednisolone dose by 5 milligrams every week. Your tapering is required to prevent the complications like adrenal crisis and others. This is a question in treatment of rheumatic disease. Low dose prednisolone therapy is less than 7.5 milligram per day, whereas medium dose is 7.5 to less than 40 milligram per day. This is in annals of rheumatic disease. This showed that different doses, low dose, medium dose, high dose of steroid. But the medium dose here is shown in this study that more than 7.5 but less than 30 milligram prednisolone equivalent a day. This is the low dose and this is the medium dose. And this concludes the last question was the patient with chronic obstructive pulmonary disease are at increased risk for osteoporosis and fracture. This is a function 8 study, and this is the randomized controlled trial. And what this, he has conducted the randomized control, a double-blind trial, and in the chart study, no significant effect on BMD was detected for inhalation of corticosteroid therapy compared with the placebo. And they conclude osteoporosis is highly prevalent in patients with COPD irrespective of the gender. Thank you. Thank you.
Thank you, Professor Tiwari. Stop, please stop sharing. Right. Now, Aarti, for some reasons, perhaps she is traveling, so she has not been able to report as yet. So the next talk is by Sitanshu Barik on Andropause. Sitanshu, it is your turn now. Please.
Thanks, sir. Is my screen visible, sir?
Right.
Yes. So good evening. So I'll be speaking about andropause and male frailty, the questions related to it. So we start with the first question. So the question was whether
Make it full screen if possible.
Is it
Sitanshu, can you go to
Right,
the
right.
Now, okay.
Yeah. So for the diagnosis of andropause or late onset hypogonadism, it is the clinical features, that is reduction of height by 2 centimeters, features of hypogonadism like erectile dysfunction, loss of libido, features of less testosterone such as generalized bone pain, depression, sleep disturbances, and the confirmation is by serum testosterone levels. So the consensus statement was the clinical findings in andropause or late onset hypogonadism include a reduction in height by more than 2 centimeters, erectile dysfunction, generalized bone pains, and depression. The diagnosis of the condition is by clinical symptoms, and signs and are confirmed by reduced serum testosterone levels. The second point is when to undergo serum testosterone levels testing. So for men over age of 65 years who have clinical symptoms of andropause, they should undergo serum testosterone testing. And usually the levels below 300 nanogram per deciliter, they are suggestive of late onset hypogonadism or andropause. So the consensus statement reached was, as testosterone levels decline with aging, all men above the age of 65 years with symptoms of andropause and osteopenia or osteoporosis are advised to undergo serum testosterone level measurements. The third question was, what are the precautions that should be taken during serum testosterone testing? So the blood samples should be collected between 7 and 9 a.m. because of the diurnal variation of the levels, and usually it is highest from 4 a.m. to 8 a.m. So as consensus statement has been reached that as osteoporosis, the BMD measurements at 2 yearly, so it should be collected between 7 and 9 a.m. The fourth was, when should the BMD be measured? The BMD measurement in hypogonadal men should be 2 yearly for confirmed hypogonadal men, and confirmed, this is the basis of the serum testosterone levels as discussed earlier. So, and osteoporosis is more common in hypogonadal men. The BMD measurements at 2 yearly intervals is recommended for the hypogonadal men. The fifth question was, what are the prerequisites for starting testosterone replacement therapy? So we have to rule out benign prostate hypertrophy, and we have to ensure that normal levels of PSA or prostate specific antigen is there. So the consensus statement reached was, cancers and prostate, there is a role for testosterone replacement therapy in osteoporosis in younger male and some elder males without contraindications after checking for BPH and levels of PSA. The next question related was, what are the contraindications for testosterone replacement therapy? So prostate cancer, breast cancer, severe lower urinary tract infections, and other noted in literature where hematocrit more than 50% with uncontrolled sleep apnea and uncontrolled heart failure are relative contraindications for testosterone replacement therapy. So the consensus statement reached was, the cancers of prostate and male breast are contraindications for testosterone replacement therapy. Now, the seventh question was, what are the dosage of testosterone replacement therapy? Now, literature suggests that the intramuscular route is usually preferred, the testosterone esters, and they are usually in the time of every 3 to 4 weeks and dosage of around 150 to 250 milligram as per weight. So the consensus statement reached was, The dosage of testosterone is 150 to 250 milligram every 3 to 4 weeks for osteoporosis reversal. The next question was how should we monitoring the testosterone replacement therapy? So they are ideally done by serum testosterone levels measurements, and we should always target to avoid a supraphysiological or a subtherapeutic level of testosterone. So a level of 400 to 700 nanogram per deciliter is acceptable, and usually 2 measurements should be taken before making dose adjustments because of the higher Daniel variation which has been noted for testosterone. So the consensus statement reached was the testosterone levels are monitored and titrated during therapy by checking the levels before the next injection. The last is how do we treat osteoporosis in these males who have been diagnosed with andropause? So even with the continuation of the testosterone replacement therapy, we should continue the treatment osteoporosis as per WHO grading, as per the previous speakers, either bisphosphonate or teriparatide or denosumab. So those treatments should be continued concurrently. So the consensus statement reached was even if a patient is on testosterone, they would require osteoporotic agents for pharmacological therapy. Thank you. So these are the 9 questions which were related to andropause.
Right. Thank you very much for limiting yourself to all those questions. Please stop share.
Yes, sir.
Right. Next is presentation by Dr. Chinmoy Das, who speaks on sarcopenia. Professor Chinmoy, you are there?
Yes, sir, I am here.
Okay.
So I can share the screen?
Oh, sure.
I think you can see it, sir.
Right.
So I thank Iowa, Professor Jha sir, Dr. Amarnath, Dr. Srinivas, and of course, all the consensus, our Delphi experts who are constantly with us since last 3 years. So my topic, which was assigned to me, was sarcopenia, and I will be just talking about the PubMed-based publications which are supporting our already developed. We have formulated the consensus statements, and only the PubMed, the publications. So our first statement was osteosarcopenia refers to simultaneous bone and muscle deterioration in aging individuals, and these are supported by the PubMed publications as way back in 2010, 2023 also we had, and they clearly said that while diagnosis and treatment of osteoporosis are well established in clinical practice, but sarcopenia was classified internationally as a disease in 2016 only. And we have got the Asia working group on osteosarcopenia, and they have also supported this diagnosis, as well as they have said that to change this diagnosis, you need more of your publications. And osteoporosis and sarcopenia, these are bone interactions with at the biomechanical, your cellular, paracrine, endocrine, neuronal, or nutritional levels. Osteoporosis, already it has been described that it's below 70% of if the BMD is below 70% of the young adult males, and the T-score is below your minus 2.5. And sarcopenia, which was diagnosed and defined by Asian working group of sarcopenia in 2019, is your deterioration in muscle strength and muscle weakness. The second statement was sedentary lifestyle and nutritional deficiencies contribute to the development of sarcopenia, and these are the documents which support it. And we have taken into consideration the standard SARC F5, examination, which examines the 5 domains: the strength, assistance, then rising from chair, the climbing stairs, and falls. And the score more than or equal to 4 out of 10 indicates sarcopenia. Our third statement was osteosarcopenia negatively impacts health and family welfare, and that's an established fact. As you know that there is, when individuals suffer a combination of both disorders, it negatively impacts the outcomes such as falls, fractures, loss of function, frailty, and mortality. Then DEXA scans, these are well established, and muscle strength assessments are used to assess osteosarcopenia. Our fifth statement was fractures, falls, and increased morbidity are complications associated with osteosarcopenia. And these are the documents which supported our statement. Our sixth statement was bone mass, muscle mass, and muscle strength are important assessment parameters in evaluation of sarcopenia associated with osteoporosis, and the following PubMed publications are in support of this statement. Our seventh statement was osteoporosis associated with sarcopenia, if not treated, finally leads to frailty. And the following documents, following publications, they support our statement. We had only 7 consensus statements made on osteosarcopenia in our Delphi consensus, but there was a query about anabolic steroids, synthetic anabolic steroids, and I went through some of the PubMed publications, and they all say that no doubt the anabolic steroids, they are in use since 1950, but if you use 50 milligram synthetic anabolic steroid intramuscularly for 18 months, they will give you a 3% increase. And most of this increase is in the initial 6 months of the therapy. So, but I may ask our intellectuals in the consensus group that whether we can add one statement like this or not on this topic, whether anabolic steroids can be used in osteoporosis or osteosarcopenia or not. So I think that is all. I take this opportunity to invite you for IOCon 25. Thank you.
Thank you, Chinmoy, for
Thank you,
making the presentation and additionally talking about anabolic steroids on a long-term use. There
Yes.
are certain complications likely to take place. Maybe some of the tumors can develop. So
Yes.
that's a gray area which needs to be explored further. May I
Yeah.
now request the last speaker, Professor Jawahar Jethwa, to delve into his topic.
Thank you, sir. Good evening to everybody. And I'm really very much thankful to Professor Jha, Amarnath, and all council members who has given me this opportunity to talk about this subject and to be with all development of this consensus and also many information regarding osteoporosis. So I think you are able to see my screen now.
Yes.
Okay, so I just open up. I'll be having a very few Delphi statements and little bit of some comments which has been published in our special supplementary. So my subject is about the rehabilitation and alternate medical therapy in osteoporosis, Delphi statement, where the first one is that referring to a physiotherapy center for prevention of osteoporosis is not warranted if the patient is otherwise healthy. That has already been discussed by Professor Ramesh Sen. But this means that walking, dancing, slow impact aerobics and stair climbing, gardening, everything can be done at home just to have a good bone density and to change the new bone from the old bone. It improves balances, also coordination, and also prevent falls and helps in preventing osteoporosis. These are the publications which are supporting this statement. The second one is attending group exercises should be allowed because patients feel better psychologically and becomes more punctual. Now that has been a very well studied in this cross-section study which has been published, where the participation in group exercise programs can improve mental health and reduce anxiety, stress, and trauma-related disorders. So there are two ways by which the mental health also is improved. The third statement is a regular planned physical activity like weight bearing or resistance exercise for 30 minutes at least 4 times a week is recommended for persons to prevent osteoporosis. A huge publication is there about 43 randomized trial controls of 4,320 participants, and they have many such recommendations that a activity and such exercises 4 times a week is very important for prevention of osteoporosis. Force and fracture prevention strategies for the elderly people, including measures like identifying and eliminating risk of falling, fall prevention exercises, eliminating obstacles, very important. You have a very small bedroom, so you need to eliminate the obstacles and improve lighting and hip protectors. Now here the publications are supporting, but there is a caution. The caution is that an individual having limited mobility and not participating in regular physical exercise, the trainer should initiate the training with caution because it may increase the chances of falling. So tailor-made exercises are very important in those cases where there is some stiffness, some problem with the old age. Now, there are some key points which has been in the related chapters in our Indian Journal Orthopedics special supplementary that assess the patient's functional, mental, social, medical, and nutritional status before recommending rehabilitation, because that makes a big difference. Avoid treatments in impacting mental state negativity, especially those who are taking antipsychotic medicines. They should not increase the depression. So we have to be very careful and take care what other psychological or psychiatric treatment patients are taking. Focus on safety in daily activities like walking, climbing steps, lifting, cooking. All this, there has to be a safety when you are recommending exercise at home. Evaluate home surroundings for the fall hazards, which is very important that you should not have any slippery fall on all those problems which can cause falls. Recommend assistive devices based on disability and deformity. So we need to ask all people that please use stick. Do not be ashamed of using sticks or other appliances for balancing their walking and all activities. Tailored exercise program include aerobic activities, posture training, resistive workouts, stretches, and balancing. Now, this is very important because otherwise you will not be able to get the output as in prevention or increase in the bone density. Now, there are some very finer aspects like what exercise and what is the effect. Exercises like weight-bearing exercises like walking, running, and playing tennis that strengthens bones and prevent osteoporosis. Non-weight-bearing exercises like swimming and yoga, good for cardiovascular health and flexibility. Then endurance exercise like cycling and aerobics are improve stamina and overall fitness levels. Strength building exercise like weight training and resistive workouts can reverse bone loss and increase muscle mass. This is very important as far as we are discussing the subject. Balance exercise like standing on one foot can help prevent falls and maintain stability in older adults. So it is not the calcium or any other level. It is not even the coordination. It is the balancing exercise which will prevent falls rather than other aspect which we are thinking, which is very much documented in literature. And that stretching exercise, important for improving flexibility and preventing injuries in bones and joints because there's good flexibility. And strenuous exercise, this is the last one, like backward running and side-to-side running is crucial for preventing osteopenia and osteoporosis, which is very strenuous. If you have tried, it is very interesting to do backward running and also side-to-side running. So avoid prolonged immobilization, which is very important. At the same time, long-term rest may cause muscle dystrophy, may cause sarcopenia. So orthosis can relieve pain and align vertebra. But at the same time, you have to see that it does not go for a long-term use. In summary, prevent and manage osteoporosis with regular checkups, exercise, healthy diet, fall prevention, medication, assistive devices, and individual rehab programs. Why? Not only because you want to prevent osteoporosis, but once treated satisfactorily, you want to prevent recurrence. So back to square one, we have to see that the patient do not develop osteoporosis once they are treated successfully. And the last Delphi statement is in primary osteoporosis, allopathic therapy should be continued even if the patient is taking approved alternate medical therapy. There are so many references which is in this chapter of our special supplementary. A book chapter has been thrown light on the potential of plant-derived natural herb or remedies in therapy of osteoporosis with quite convincing and encouraging results. So friends, it is not an alternate medical therapy. It is an alternate scientific medical therapy. That is what we have found through going through this literature. So I thank you very much once again for giving me this opportunity. Thank you, sir.
Thank you, Professor Jawahar, for giving lot of inputs apart from the questions, and regarding prolonged bracing, your all the points that you have put forward is so very much important. Now we come to the most important part, discussion. Well, Professor Chandrasekhar, are you there? Professor Chandrasekhar, please.
Yes, sir.
Right. Thank you very much for staying with us throughout the program. Now, our whole aim of doing this webinar was to aim at, have we left out on some of the important points that should have been there when we are going to format the guidelines. So could you outline some deficit areas?
Yeah, I think it was really a very nice, very comprehensive output that I could hear. Of course, few things which are I could, of course, was not discussed. Of course, it was there in the Delphi questionnaire, was about the osteoporosis with reference to rheumatic diseases, like in rheumatoid arthritis, when to screen, when not to screen. Anyway, they are all there in the Delphi questions.
No, it was here also. Dr. Ramesh, yes, yes, it was. All the questions.
So otherwise, I think it's quite comprehensive. I didn't see much of the gaps to be really filled with. Actually.
Right. Talking about secondary osteoporosis, you took up the cause of rheumatoid. Dr. Tiwari talked about respiratory condition, but as far as osteoporosis concerned, with these two conditions are concerned, the treatment remains the same, is based on the T-score, but renal conditions, they acquire a special situation because the treatment has to be modified as per the function of the renal diseases. Well, Professor Tiwari, I would like to know from you, parathyroid has lot to play, and we do not talk so much about thyroid. So when it comes to parathyroid, it is said primary hyperparathyroidism, secondary and tertiary. Would you like to make comment on these three conditions?
Yeah, chronic kidney disease presents with the secondary hyperparathyroidism. Because there is hypocalcemia. Because vitamin D3 is mainly synthesized, converted B2 to D3 in the kidney. And that leads to the, if hypocalcemia is there, that compensatory mechanism that stimulates the parathyroid. And parathyroid acts on the bone, and that osteoclastic activity increases and causing hypocalcemia. And that is hyperparathyroidism. And hyperparathyroidism leads to the dynamic bone disease. And that is the main thing, which usually is seen in the stage 3 and 4 of the chronic kidney disease. And that is also in early stages causing the osteoporosis, stage 1, 2, 3. So that, but only thing that we're using the teriparatide, usually you have to use the PPH level, but in chronic kidney disease, hyperparathyroidism, you should not use the teriparatide. That is the main thing. But primary hyperparathyroidism usually seen the parathyroid adenoma and those things. But secondary parathyroidism, hyperparathyroidism is seen in the chronic kidney disease.
Right. Professor Chandrasekhar, would you like to comment on thyroid and its treatment? No, you are muted.
In a clinical setting, we do see sometimes the patients primarily with hyperparathyroid or parathyroid who come with a severe osteoporosis and osteoporotic pain. Of course, the management basically depends, as alluded, it's primary or secondary. And most of the primary, I think, if possible, surgical, or we go with hypervitamin D management. So it's more go into the hyperparathyroid management rather than focusing on osteoporosis.
Right. Well, Dr. Renuka, are you there?
No, she's...
Okay, fine. So, Professor Ramesh. Professor Ramesh, are you there? Yes. I would like to draw attention to the first question in the bisphosphonate group, which I had talked in my last presentation also. We say ideal indication for osteoporosis is primary osteoporosis, but I think because of some typographical mistake, we had entered a word adynamic, and simultaneously we wrote high turnover disease. They are contradictory. So adynamic bone disease is always low turnover. So this question will have to be redefined once again, that ideal indication remains primary osteoporosis, which itself includes type A and type B. That means premenopausal and adult osteoporosis. We might add high turnover bone disease also inclusive, which will include states like hyperparathyroidism. Any comment about it, Dr. Chandrasekhar? Right, again you are muted.
No, nothing specific.
Okay, right. So I have taken up. We have discussed about osteomalacia also. So how osteomalacia and adynamic bone disease are different. So they are definitely different, but both are low turnover bone diseases, and there is subnormal rate of collagen synthesis by osteoblast, and there is subsequent mineralization of bone collagen. So two things are subnormal. In osteomalacia, the second thing exceeds the defect in bone formation, whereas in adynamic bone disease, bone formation defect exceeds mineralization. So we should be confident when we are talking about adynamic bone disease that it is also known as aplastic bone disease, and this is a low bone turnover without osteoid accumulation, whereas osteomalacia, there is a lot of osteoid accumulation. Now, various factors. Coming back to how frequently the patient should be monitored frequently with BMD assessment. Professor Chandrasekhar, would you like to say something?
Yes, sir. Actually, preferably it is said once in 6 months or a year. But in a setup like in India, where we need to look at the economics and availability, maybe once in 2 years is what we normally do in a clinical practice, because usually changeover of the treatment we think about after the end of 2 years. If I say start PTH, it's end of 2 years, I take a think over on changing. If I start an bisphosphonate, we think about altering it after the 2 years. So that's a point where we normally tend to reassess whether the things have worked. Or if we find any reason that the improvement with reference to osteoporosis is not as much expected, sometimes we repeat in our clinical practice at 6 months.
All right.
Sir, how do you decide, sir, how do you decide
Yes.
what is adequate improvement and when to start therapy? Dr. Tiwari.
So
When do you start therapy, and what stage do you see patients with osteoporosis? And then what is your game plan? That's because I wonder, as a rheumatologist, who refers an osteoporotic to you, and when do you start treatment for the same?
So normally, as we said, most of the patients I see are rheumatology patients, with an exceptions. Once in a while, we see osteoarthritis or any other senior citizens walking in with some pains and aches. Normally, once we look into the possible fracture risk as well as the BMD or any other assessment, suggest individual to have an osteoporosis like -2.4 and above, -2.4 and below. At that point of time, we take a call to start the patient on the treatment. Primarily, we look at, is there any other secondary causes which need to be worked with? So we look all the metabolic workup that has been suggested, and we look into the how good or how best the control of the rheumatological diseases are there. And then we look for any other things. If there is nothing which is correctable, then we go as we discussed about whether it is dynamic or whether it is the more of bone turnover and any other risk factors which are present. Based on that, we initiate and pick and choose either alendronate, bisphosphonate, or denosumab or PTH. And once we start it, usually we are just looking forward for is there any changes or any improvement, or does he sustain a fracture when we are on treatment? I mean, those are the time when we try to take a reassessment that is real things are going on. Otherwise, normally I tend to reassess at the end of 2 years when we take a call to go for a drug holiday with either bisphosphonate, PTH, or switch over to any other different modalities.
So my little experience from JIPMER is when I used to see juvenile rheumatoids, they're coming to me at around 25, 30 years of age for replacement. Now, these people are already severely osteoporotic because from the age of 8 or 9, they are on steroids, juvenile rheumatoid. What are your recommendations for such patients? Should we be putting them on anti-resorptives or, drugs like that?
So the best in them is to use the denosumab, preferably basically because in them it is IL-6 or TNF-driven osteoporosis, and it is more often because of rank-rankle ligands overexpression. So that's where if you use the denosumab, you get a better results and better outcome with reference to these patients. Usually, parathormone and others analogs may not much help. Bisphosphonate, if there is affordability issue, can be tried, but we prefer to avoid if possible. I mean, when sometimes it comes to a point where the patients, even if you prescribe denosumab, he may not go with it at that point. I suggest them more to go with bisphosphonate or those group of drugs.
Right. Professor Ramesh? Professor Ramesh? Yes. So we had overall discussion about the questions that were there. Some deficit areas have been located. What is your overall impression now?
Sir, as far we had started with the perception that we should be able to give answers to most of the commonly encountered problems. And I think with the current set of questions, we have been able to tackle almost every perspective, whatever was required. So I'm quite happy, and maybe the little deficit with the rheumatoid was there, so that can be covered if we have to put them into questions. So that definitely is an important perspective, because rheumatoid being a very, very common problem and osteoporosis being reasonably common, probably we had missed that part of it. And once that is also included, so probably it will complete the things.
Talking about bisphosphonate, I would like to say that in premenopausal women who are likely to conceive, it should also not be used because of the likely teratogenic effect. because one advantage, or in a way disadvantage, that it does not clear out from the bones for very, very long time, minimum being maybe 10 years. So for decades it is there. There is one drug, leflunomide, which also remains there in the body, but then it can be removed. This one cannot be removed by any method. So this particular point, that it should not be used even in a lady who is likely to conceive, should be remembered. So only safe drug during pregnancy remains
PTH analog.
Right.
Teriparatide.
Right.
Denosumab, we are still unsure because there are no adequate exposure trial with reference to denosumab.
Professor Rajesh.
Sir, one question, if you may, Dr. Jha. What about ankylosing spondylitis? What is the incidence of osteoporosis and ankylosing spondylitis? We as orthopedic surgeons see a good amount of ankylosing and rheumatoid in young age groups. And I don't think we pay adequate attention to the bone quality in these patients, especially because when I did both hips and both knees in a young rheumatoid of around 27 years of age, in around 2010, I could find that I could actually take off the bone with my fingers. I could scrape off the bone with my fingers during surgery. So, I mean, this is a very challenging situation for an orthopedic surgeon. So, what are your recommendations to us before and after surgery?
Right, sir. So, with reference to rheumatoid, actually, if rheumatoid is fairly well managed with good amount of DMRs, and if we maintain a DAS score below 2.6 throughout, or even at least close to 3, usually osteoporosis is not going to be much of a serious consequence. If the steroid is not used in a higher dose for a longer time. So usually preferred dose is around 5 milligram or still 2.5 milligram of prednisolone, but that also preferably be avoided if you use good amount of DMRs. Actually, in most of the studies of late and most of the centers, steroid is not very commonly used at all in management of rheumatoid arthritis. So osteoporosis is not a serious issue, but still in a less or not properly controlled rheumatoid arthritis, osteoporosis is going to be an issue where a pre-assessment before replacement is a best way to handle it further. If there is an osteoporosis, rectify the osteoporosis and then to move ahead with the replacement or surgery, because some of the reason for the failed replacements in rheumatoid arthritis, what I see is failed assessment or a pre-assessment about osteoporosis and other problems related to the neighboring joints. These are the two common reasons why the replacement is not as successful as I see in osteoarthritis patients. This is one of the area where one need to assess, probably putting that as one of the recommendation in maybe of some great help.
Yes, this is very interesting. Very, very interesting,
Yes.
sir. I like that. Dr. Jetwa,
Right.
sir.
Thank you very much. Only just after one statement. We don't have much time left. We had planned for up to 10:30 only. So what I would like to again discuss, that the best part of it was, now we know that majority of the statements that we had made, we have got suitable references for all of them. So that is one achievement. And now I would like Dr. Srinivas to make a comment after Dr. Jawahar has
So my comment is similar. Dr. Chandrasekhar and Murali has the same point I am asking, that there is an orthopedic surgeon day in, day out. There are two surgeries he is doing. One is joint replacement, second is fracture surgery. For joint replacement, you have given a time that you prepare the patient. If there is an osteoporosis, wait and then do. But for the fracture treatment, in an osteoporotic bone, the only thing we can recommend is the post-operative regimen will be different because it is not as good as that. So that is one part. And second part which I would like to emphasize is monitoring. If you are monitoring only Denosumab and Teriparatide and their duration and all those things, we also have to monitor whether they have started exercise, whether they have started good diet, whether they have started all these which can prevent osteoporosis. So just thinking of 2 years is not important. 6 months and all these things will be enough. Not that every time you have to go for 2 years. So that is what is probably the part of monitoring, not only the medicines.
Right. So, yes,
Yes.
it is your turn. Right.
Just one rheumatological basically, and one for joints. The rheumatological query is that, inflammatory arthritis can set in from childhood to even elderly patients. So how do you choose to look between T-score and Z-score in these patients when you are assessing for osteoporosis? The other question is there a safe cutoff for osteoporosis before we go ahead with a joint replacement?
Sir, I think the first question, the problem is with reference to pediatric population, we really don't have a good standard publications, which are the best Z-score or T-scores, where we can take a cutoff. So it's based on the clinical experience, and we almost use the same numbers that what we use with reference to the T-score, the age-matched scores. Based on that, on the bone mass, we can say whether the child has osteoporosis or not, and a suitable rectification has to be done. The second question is actually, I went through because we had a problem recently too with reference to a replacement. There is no literature which has really worked in to say that this is the best safe score where one can think of replacing or defer the replacement. So the reason is actually, and as Doctor was saying previously, that when it becomes a fracture, you have less choice. You need to fix it and then think of fixing the osteoporosis. The same principle can also be applied when you're replacing the joint. You replace the joint and you can still try to fix the osteoporosis. But of course, you have a choice when you're going for a replacement. I don't think there is any serious studies that has taken up or taken around. Probably IOA as a group, I think, since I have a large number of replacement surgeons in this group, can take up this study, probably should give us some guidelines that when and where we can really say that don't do the replacement now, wait for a couple of months or 6 months, get this fixed and then go ahead. I couldn't
This
find
is very, very interesting, Dr. Tiwari, because this is
Dr.
something,
Mohit, are you there? Dr. Mohit? Mohit? No.
Okay.
Dr. Jha?
Yeah. You have appeared, right. Yes,
Dr. Jha, there are quite a few questions from the delegates, which has been posted in the chat from Ortho TV.
Okay, please.
Do we need to address it? Can we have that?
Yes.
Okay. Dr. Suryanarayan Rao Akela, to Dr. Srinivas Kambhampati, he says, is the National Osteoporosis Foundation criteria laid down by IOA? Srinivas.
Again, say it again. Dr. Srinivas, will you like to...
Suryanarayan Rao is asking to Dr. Kambhampati, is the NOF criteria laid down by IOA?
No.
Well, put in the guidelines. We have looked into all the guidelines.
Yes.
The NOF guideline is a part of it. But Indian guidelines are different. Come on, Srinivas, would you want to answer that?
So NOF guidelines are different from IOA. We are just now developing the Delphi consensus. So those are different.
Wonderful. Now, there's another question. The other question is, role of vitamin D3 in thyroid disease, lasting more than 10 years, and its effects on bone in causing osteoporosis. Should I take that?
Yes, you can take, please.
Okay, I'll repeat the question. Role of vitamin D3 in thyroid disease. It could be hypo or hyper. He has not mentioned that. We take it as hypo probably. Lasting more than 10 years and its effect on bone in causing osteoporosis. I think this question, doctor, what I would recommend, see, parathyroid is the hormone for calcium, and vitamin D. Thyroid, being a autoimmune disease, definitely has a play, but parathyroid has to be attended. That is one thing. Two, while putting the thyroid patients on thyroid medications, we need to definitely address the hypercalcemia as well as osteomalacia. Yes, we need to definitely address that so that osteoporosis can be kept at bay. Now, the next question is it mandatory to do DEXA scan after 2 years?
Sir, may I interrupt, sir?
Yes, yes.
Sir,
Please go on.
regarding this thyroid, hypothyroid or hyperthyroid, actually, I found in literature that TSH level is more this thing for osteosarcopenia, a high level of TSH, not T3 or T4.
Not for osteoporosis.
Both for osteoporosis and sarcopenia. TSH level is more indicative, or it should be examined also. They have recommended that it should be examined, the TSH level, for diagnosing osteosarcopenia.
Yeah, I think what Professor Chinmoy was saying the same. The adequate control of TSH is something what is looked. If the mean control of TSH somewhere lies in the most of the time between 2.5 to 3.5, rather than either on the higher side or the lower side, is said to be one of the predisposing factor or predicting factor for development of osteoporosis in hypothyroid. And the other reason they say in hypothyroid, the reason why they are likely to have a higher tendency to develop osteoporosis compared to their counterpart is somehow, for a reason unknown, calcium metabolism are disturbed in the patients with hypothyroidism. So both absorption and this thing, not adequate explanation is there, but that is in some small segment of these hypothyroid patients, they have little altered calcium metabolics.
Even the treatment that is given for thyroid patient, hyperthyroid patient, that also has influence on calcium. Right.
One last question.
Right.
So go on.
No, please go ahead.
Great. One last question, probably to end the discussion on the questions been asked, and I will ask Aarti TV for us to pass on the questions so they could review and appropriately address them. The last question here is it mandatory to do DEXA scan after 2 years if we start treatment either with zoledronic acid or teriparatide? So the doctor is asking, is 2 years mandatory?
No, he is asking most probably because the facility may not be available and he is doing blind treatment. But if facilities are available and the patient can afford it, if he has to pay for it, you must go for DEXA scan monitoring, maybe after 1.5 years to 3 years.
So it is very highly informative.
We are coming to you. So, Dr. Srinivas, you had a question about Z score. So, Z score is worth consideration in children because the definition of pediatric osteoporosis is connected with Z score and not T score. Number two, in patients of secondary osteoporosis due to steroid and those who are younger than 40 years, it is the Z score which determines whether low, medium or high risk of fractures are there. So Z scores also have a value. Now, Dr. Gupta, Rajesh Gupta will make the comment and then finally it will be concluded by Dr. Dilip Mazumdar.
No, sir, very well covered. I think every topic was very well covered, from A to Z, you are there on the consensus already. So few things, I was concerned was again in rheumatology diseases like rheumatoid arthritis, especially juvenile rheumatoid arthritis is the issue. That is a concern, I think a few points were very well covered in that also. when to do, DEXA in juvenile people and when to start the treatment, what treatment on those people. That is the thing. Few other, secondary causes were also covered, like hypothyroidism, hyperparathyroidism, and everything. I think most of the things are covered. But regarding the, sir, fragility fractures, when the patient, comes with us with a fracture and we have to fix it, patient, when to, screen the patient. We don't have the time to screen the patient for that. Patient may be in the ward for 10 days, 20 days, and when to start the treatment. That is from the surgeon's perspective.
Right. So as far as pediatric or osteoporosis is concerned, there are very many drugs which are not routinely used in adult osteoporosis. A drug like losartan, that also ACE inhibitors, they are also being used for osteoporosis. We have palmidronate to be used as IV infusion. So now we will like Dr. Dilip Mazumdar to make his final analysis and comment. Right.
Yeah. Comment, everything is covered fine. Dr. Srinivas has told about the ankylosing spondylitis above 40 years. Screening is a must. Giriraj Dr. Giriraj has told about the camp or the USG, because we do the USG from the hill. It is not conclusive. And DEXA scan he has actually told about. And another thing is that hypoalbuminuria is actually very important for the because it falsely gives the serum calcium level. Amarnath has told nicely and comprehensively about the 60,000 international unit loading dose and correctional dose, also vitamin D he has told. And in osteomalacia, he has very nicely elaborated. Professor Jha regarding the bisphosphonate zoledronic acid, 5 milligram, 3 years, very nice. Bharat Dave is a miracle molecule about the teriparatide. Usko Jaigan very nicely he has done, and the 2 years can be used. Regarding parathormone and calcium level, he has warned. Teriparatide, Denosumab also he has done. Joy Prakash Tiwari, secondary osteoporosis, he has.
Sir, your mic is muted. Sir.
Right. Now, till the time that he is not there.
COPD he has highlighted. All these things he has highlighted. And he is above 65. This actually very important for the serum testosterone level. Then coming to your this Chinmoy. Chinmoy has done very nice, but regarding the muscle mass and the muscle mass, bone mass, and the muscle strength, this is important. But the controversy is the anabolic steroid. So Jawahar Jetwa has told very nicely about the rehabilitation. But I was actually wondering whether the preventing aspects also goes towards the accessories in the bathroom, accessories in the stairs, accessories in carpet, accessories in all like that. So thank you all of you for the nice coverage.
Okay, right. I have just to raise one question. Professor Ramesh, you are also there. I was looking into the reference of bisphosphonate IV, that means zoledronate IV. So we have made a statement that 5 milligram for 3 years. While looking into references, I have also found that people are not using 5 milligram, they are using only 4 milligram, and then they have used it for 5 years. So maybe here also we have to make some amendments, because 4 milligram is being routinely used by our oncologists, and that comes very cheap. So only 1 gram difference, and average body weight of our patients are lower than the Western population. So we can think of advocating 4
Yeah, right.
milligram in our recommendation. Professor Chandrasekhar, any quick comment on this?
Yeah, you're right, sir. I think it's best we amend it actually,
Right,
because that's easily available too.
right,
And effect is not really big difference as per this studies.
right. Now is the turn of Professor Amarnath to say us goodbye and thanks. Yes. Chairman,
Muted.
you are muted.
You are
Amarnath,
muted.
you are muted.
Sorry. Thank you. I think it's a late night now. Naturally, the signals are showing the wonderful. I think it has been said enough. I think we need to thank, and any amount of thanks is not enough for all our Delphi members.
Right.
Tirelessly working from day in, day out and giving their feedback and then answering the questions and then, coming back on that. And then Srinivas and Chinmoy has been literally at the back of them. And then the Chinmoy being the whip master for that. So thank you, Chinmoy. And Dr. Jha has been coordinating each and every point, and the deficiency, the lacuna has been covered. And Professor Ramesh Sen has always looked at giving the Delphi consensus, because we need to have the peer review. Hence, the initial survey with orthopedic surgeons to get the knowledge, and then the peer review with the Delphi coming in, and Professor Maini talking to us, and then you people have done so much of work. Why don't we have, a coffee table reference book? That's been done as well. So fantastic with the editors, sub-editors, and associate editors, Murali and Srinivas and the entire team. And obviously, our specialist non-orthopedic surgeons who are also present, not just now, on time and again, giving their feedback in the subspecialties of rheumatoid, nephrology, gynecology, endocrinology, all that has been covered. And I think we're going to have a comprehensive, we will amend for 1 or 2 questions back and forth what has been suggested today. 2, we'll also look at the questions that have been collected by Ortho TV in the next couple of days. And then we will collate, and then we will definitely come to, solid consensus. Thank you, team. Thank you, each and everyone.
Thank you.
I should thank
Dilip, Professor
Dilip and Rajesh.
Chandrasekhar once again for being present throughout.
Absolutely.
Thank you, sir. Thank you, sir.
It's a privilege to be there.
And also our Rajesh, who goes fast.
Yes.
Oh, he is
Who goes
absolutely
fast into sleep.
Right.
He goes fast to sleep.
Right.
No, sir, no, I'm not sleeping.
No. He practices till 10:30.
No, sir. Today I'm at home, at 9. No, don't worry.
Okay, sir.
I listened all the talks. Sir.
Okay, bye. Good
Thank
night.
you, sir. Thank you very much.
Good night, sir.
Everybody.
Good night. Good night.
Bye, sir.
everyone.
Good night, everybody. Good night. Good night.
Bye.
Bye.